Well, welcome everyone, faculty, students, and guests to our quarterly FNU IHI chapter event. It is with great pleasure that I introduce our distinguished guest speaker, Dr. Debra Bingham. Dr. Bingham has over 30 years experience in maternal child health nursing, a master's degree in perinatal nursing from Columbia University, and a doctorate in public health from the University of North Carolina, Chapel Hill. Most of Debra's career has been spent working in hospital leadership positions at the front lines of healthcare, and she has combined this with an expertise in quality improvement, healthcare safety, and implementation science. She has led numerous QI interdisciplinary initiatives designed to improve the safety of healthcare and is well published in quality improvement and toolkit implementation. Dr. Bingham was the first executive director of the California Maternal Quality Care Collaborative, CMQCC. She was the Vice President of Research, Education, and Practice for the Association of Women's Health Obstetrics and Neonatal Nurses, otherwise known as AWON, and Chair of Patient Safety and Women's Healthcare. Currently, Dr. Bingham is an Associate Professor of Healthcare, Quality, and Safety at the University of Maryland School of Nursing, a perinatal consultant, and founder and Executive Director of the Institute for Perinatal Quality Improvement. And therefore, without further ado, I give you Dr. Bingham.
Thank you. Nice to be with you all tonight. So tonight's presentation will be about who is responsible for quality improvement. I wanted to make sure I point out some disclosures. As the Executive Director of the Institute for Perinatal Quality Improvement, I consult for National Perinatal Information Center, still consult for AWON, and I am an Associate Professor at the University of Maryland School of Nursing. I will not discuss any off-label use or investigational use in my presentation. Just to point out the copyright statement that these slides are owned by the Institute for Perinatal Quality Improvement and all rights are reserved for this presentation. To request permission to use one or more of the slides or to modify a slide, just contact info@perinatalqi.org. So I'm going to go over briefly why all clinicians need to learn quality improvement concepts, methods, and tools, and then I'll describe why the Institute for Perinatal Quality Improvement was formed. So many of you know this very upsetting statistic that there's a 17-year research to action gap. And that's even when we're trying to implement evidence-based care. And even then, it's also highly uneven. And so there has been also the Hastings Center, which is an ethics think tank for one of the premier ethics think tanks in the United States. Back in 2007, published a report about QI and the ethics of QI. And in that, they defined QI as that they mean systematic, data-guided activities designed to bring about immediate positive changes in the delivery of healthcare in particular settings. They also say who's responsible for implementing the quality of care, or for improving quality of care. And this is from that report. It says, we conclude that engaging in quality improvement is not purely discretionary. Health professionals, managers, delivery organizations, patients, and government all have an ethical responsibility to cooperate with one another to improve the quality of care. Now, since you're all working on getting a doctorate in nursing practice, you are really extending yourself to learn quality improvement, because that's really the domain, the scholarly domain of a doctorate in nursing practice, is that translation of research into action. Whereas a PhD is really for studying, researching new treatments and identifying new evidence. So unfortunately, though, most clinicians have not received education on implementation science theories, frameworks, or models, or even QI concepts, methods, and tools. And thank you for those who responded to the survey. Many of you are above the average, where you have some expertise or a minimum proficient in these for those questions that we asked. But many of you also still had areas in which you were wanting more information. So I'm going to just assume you know quite a bit tonight, and I'm going to jump into some of the higher concepts, more about implementation science. And why is it important for clinicians to know about implementation science, theories, frameworks, and models? Well, I think it's important because, and I actually wrote a blog about this, and I called it Implementation is the Physiology of Quality Improvement. If you've been a part of a QI effort, I have, that has felt like a waste of time. And have you ever gone to a meeting after a meeting or collected a lot of data, but no changes were ever made? I have. I've been to some of those kinds of efforts. Or have you made changes that did not improve outcomes? So that I wrote a blog about using implementation science in order to be able to understand quality improvement better. So a knowledge of maternal fetal physiology helps clinicians tailor care decisions to individual patients. Similarly, an understanding of the physiology or science behind QI makes it possible for clinicians to more thoroughly select the QI strategies and tactics they employ to ensure QI success. So let me just, another way to describe that. So this is a picture of a fetal monitor reading. And so in my blog, I talk about how when I first started taking care of women in labor, I didn't really understand the physiology behind the patterns I was seeing. For those of you that aren't perinatal, another example would be is like learning how to take a blood pressure versus being able to understand what's making the blood pressure high or low. So implementation theories are used for predicting and explaining, and they outline a fact or a set of facts and ideas that either explain or predict implementation effectiveness. And the research is outlined in theories is the solid foundation for all QI efforts. And there are some classic theories, and then there's also some implementation theories. And one example of a classic theory is Rogers' theory of diffusion of innovations. And then more implementation theories would be Weiner's theory of organizational readiness for change and Klein and Sora's determinants and consequences of implementation effectiveness. And I think you can raise hands, but maybe not. But I'd be curious if any of you know any of these. I'll actually show the Klein and Sora and Rogers a little later in the slides. But yeah, these are very helpful, I think, for implementation as implementation theories. Implementation frameworks are used for planning and adjusting the QI implementation strategies and tactics. They help describe and identify potential QI implementation barriers and facilitators. And they are also another name that you'll hear about. Some of these frameworks would be determinant frameworks. And some examples of these frameworks would be Harvey and Kitson's Integrated Promoting Action on Research Implementation in Health Sciences, or the IPARIS. And then the Laura Dramschouder's Consolidated Framework for Implementation Research, or often referred to as CFIR. And I put the website here because the CFIRguide.org is really rich with all kinds of information. And in fact, I really recommend that you become very familiar with those two frameworks. They will help you and guide you in designing your DMP QI projects. And also at the CFIRguide.org website, you'll find a whole code book. And I think just understanding and having clear definitions that have been laid out and are derived from others' research is very thoughtfully done, and will be give you a lot of save you a lot of time trying to understand certain concepts and also making sure you use proper terminology. Implementation process models are what most people are more familiar with. They're used like as checklists and guides for writing up the QI plan or a protocol. So I think of them similar to a research protocol, just like you need to know the science behind your research protocol, but you still need a research protocol to kind of talk about the step-by-step approach you're going to take in your research. The same thing applies to QI. You need a very clear plan of action And these process models help give kind of a structure to that plan. And some examples of process models that you're probably familiar with would be the mobilize, assess, plan, implement, track. If you're into public health or community health, that's one that's very popular in that group. Plan, do, study, act is also used a lot. There's the Stetler model, knowledge to action framework, and Iowa model are also other very common models you will see that fit within that definition. There's more in each of these categories. I just gave you a few examples. So again, why study implementation science? Simply, one of the things I think is I hear people say, oh, change is hard and it's so messy. But I don't think that's very helpful to just acknowledge change is hard and messy, but without understanding and digging in and trying to understand what makes it so messy and hard. And also just teaching QI leaders about QI tips and tools also doesn't adequately prepare them to know what to do. And in fact, that I find that I get kind of, I've gotten a little frustrated. I get invited to speak about hemorrhage and how to implement the hemorrhage toolkit. And I've gotten more interested in teaching people more than I can tell them in 1 hour about the hemorrhage toolkit. So I've designed an entire day just about QI, implementing QI. So also I've come up with, been thinking about, and I hear a lot of confusion when I'm out and talking to people about evidence-based practice and PICO. And sometimes people talk about evidence-based practice and get it kind of confused in like QI. Evidence-based practice is just simply reviewing of the literature and clearly understanding the literature. So that's very important. And I don't mean to say it will take often a lot of time, but it is the foundation for both research and QI. It's not the end of the effort. It's just the very beginning, as you all know. So I put together an actual what I call a flow chart to help highlight the distinctions and interactions between evidence-based practice, quality improvement, research, improvement science flow chart. So you can see that on the left is the evidence. You review the evidence. It can be population health data. It can be literature review. All of those things fit into your data. And that can feed into what maybe more research is needed. Or maybe you have identified the standard of care, such as we all know washing hands is very important before taking care of patients. So if we have an evidence-based practice like washing hands, where everyone knows what the best practice is, then you move across to the area where you go into designing and implementing a QI initiative. And then the science, the Q implementation science research and improvement science, translational information all helps guide the implementation, the QI initiatives. And then you want to move into evaluation. Then that's been this little breaking it apart like this has been actually helpful for people to kind of help clarify what they're actually working on and how they relate and how they're different. So clinicians need QI education and QI support. I feel very strongly that every nurse, every doctor, every midwife, all clinicians should understand QI methods and concepts and also understand QI tools. I also then I spent some time thinking about how do I take the theories, the implementation theories, and also then the determinant frameworks and kind of understand them together. And so that's what this slide is it's kind of this attempt to do that. I don't have time to really spend a lot on it, but let me just describe a little bit about it. So this is Roger's 3 stages of implementing innovations. Before you get to implementation, you have knowledge, persuasion, and decision. Then Kitson and Harvey's work is innovation, context, recipients, and facilitation, and they all fit in this area of the Klein-Sora framework. So, theoretical theory. So, and then you can see like all of these other elements that have been have been shown to cause and effect implementation effectiveness and how they interrelate with each other. And I think this is very important as you're working on designing your QI project, is to really attune to the climate for implementation, the types of skills, innovation, values, fit, and the commitment and enthusiasm is one that I particularly highlight. If you're not excited and you're not very committed as leaders, then I've noticed many times how that will be the downfall for a QI project. And then implementation effectiveness feeds into innovation effectiveness, and it's basically showing that success breeds success. So obviously you can spend more time reading about that and thinking about that, but I find that it's fun for me to kind of put those together and try to understand them together. So again, frameworks are based on research and they outline causal relationships. QI process models are models that provide step-by-step approach to developing a QI plan. So, and then here's PDSA as an example of a process model, and here's MAPIT. And just to remind you, like there's also like, so if you're writing up a project plan or protocol, I actually have developed a worksheet for MAPIT, and you can get that at my website. You can just download that for free. And that's just, and I put in some questions to kind of help guide the answering of like what to include in your protocol, in your process model. And this shows you where you would find that on the website. So this is my website, which is perinatalqi.org. And then you would go to blogs and tools, and then you just come up with you click on the worksheet, and then it's here, and you just click on that and it will download for free. And then the MAPIT, just like PDSA, it's cyclical. You want to repeat your cycles until you make improvements. And I like to think about it as a spiral staircase where you're headed up towards the light, you're getting better, and each cycle gets you closer to your goal. So again, I think physicians, RNs, midwives all have critical insights that will help improve quality and safety. And the more clinicians understand about QI methods, concepts, and tools, the faster care can be improved. So the second piece was to talk about, Judy asked me to talk about why I formed the Institute for Perinatal Quality Improvement. And I can't talk about why without showing you this very sad story of the rise in maternal mortality. Now, it's now hit the news quite a bit. I'm sure many of you have heard of the rise in maternal mortality, but it is, when you look at this, this figure, it's very concerning. In addition, we know that racial disparities persist, and Black women are 3 to 4 times more likely to die when giving birth than women of all other races and ethnicities. But obstetric hemorrhage related mortality is also the tip of the iceberg, as well as just mortality in general. And this is just because I do so much work around hemorrhage, this just points out like 75%, there's been an increase in maternal complications and 183% increase in blood transfusions in just a 10-year period. And we know from data, from reviews of deaths, that women are dying because they are suffering injuries because they're not getting early, effective, and aggressive life-saving treatments. So that's where the QI and the Institute comes in. So I encourage people not to be afraid to look at their QI data, especially nurses, who sometimes QI data has gotten a bad reputation because it hasn't always been data that they've chosen to look at, and kind of they've just been collecting data for other people's interests. But I think when you have a QI issue that you're working on and with data, it's much more fun to have your own data. But this is also, I think, very interesting. So the work I helped lead in California and help get started there, California is the blue line now. It's the only state so far where where there's been this trend going down, and the rest of the country's going up still. So that brings us to the realization QI saves lives, and that's, but one of the things that I found in leading QI efforts is the lack of QI expertise, lack of capacity in that area is slowing us down in our abilities to really make a difference. So the mission of the Institute for Perinatal Quality Improvement is to expand the use of improvement science in order to eliminate preventable perinatal morbidity and mortality and end perinatal racial and ethnic disparities. Now that's a very audacious goal, and we won't be able to do that without partners. And how we plan to accomplish this mission is to increase the effectiveness and transparency of perinatal quality improvement efforts. And I'll show you one thing we're doing is we've come up with a map where people can put their projects on, which will also enhance communication and collaboration. And then we're developing case studies of maternal morbidity and neonatal morbidity and mortality case root studies, and identifying the lessons learned from these case studies. And then supporting the development and implementation of research-based action plans that can be adapted. So these action plans are to help us be able to adapt at the local level. So these solutions are a project map, action briefs, maternal and neonatal, and action community around those briefs, PQI blog, and PQI tools, many of which are free. You don't need to, you can just sign up to get them, or you can just go to the website to share. We also we're hosting our first conference, a day-long conference in New York City in a week. And we're also looking for other people who want to host this conference in other parts of the country. We have, you can sign up. We have health professional individual memberships, as well as facility memberships, as well as basic individual membership that's free, as well as the updates that's free. Now, if somebody signs up for the free, they can do they get all of these elements. They can put their projects on the map for free. You don't have to be a paid subscriber to put your project on the map, but they will only have limited search capability. We wanted to keep the full search capability for the individuals who have who chose to subscribe, and that helps protect people's work and puts it behind a little bit, and it helps support our mission. In addition, individuals who sign up get 2 action briefs a year, and they also get discounts on conferences and other things. There's also facility subscriptions. So if a hospital facility signed up, then everybody at that hospital can receive access to all of the action briefs and the education. So that's which is, I think, a very desirable way to go. So the action briefs, I think I skipped over that other slide pretty quickly, but you can see that you can go here to sign up, and then you can sign up, then you just sign in to access the action briefs. And the action briefs then are case studies. And the first case study is a postpartum hemorrhage. And it includes the case study with guidance for identifying setting priorities, education on postpartum hemorrhage, and education on quality improvement concepts, methods, and tools. Also has facilitator notes and action plan templates. So here's an example of one of the things that helps walk the team through is making a list of QI opportunities based on the case, then helping them think about setting priorities for their facility. And so here's an example of like, for that particular first case, these were some of the lessons learned or QI opportunities that could be identified in that case. And then rather than, in addition, moving towards our mission of expanding implementation science at the front lines, we're using the case approach, the story approach, but then we include very specific driver diagrams, logic models, force field analysis, using that case. So it's rather than just showing some example that doesn't have relevance to a particular story. We think that the story will help everyone learn better. And I think, again, people learn from examples. Also, it saves them time because then they just get these pre-developed slides. Also, I've learned that there's sometimes some people can have emotions around a case that went bad at their own facility. So this kind of keeps it that they can maybe learn a little without being sensitive or, stepping on toes because it's a case that could have happened anywhere, but didn't happen at their place. I suggest that they also learn from the ones that happen at their facility, but this may be a good place to begin and start to help them learn how to do that. And it infuses concepts around implementation science and quality improvement because it has a whole section just on quality improvement methods as part of the action brief. So my hope is that will help do that. In addition, we offer the PQI champions. So PQI stands for Perinatal Quality Improvement, and we are highlighting PQI champions. These are free webinars highlighting great work that people are doing, and so that will help, I think, spread information about what's working, what's not working, and they will discuss tools and methods that they've used within their projects. Our first PQI champion webinar presenter is Sarah Rhodes, and she'll be talking about improvement utilizing telehealth and connected health. You do need to go on to register for this, but it is free, and it will be on February 6th. Now, the last thing I'm going to go over, and I know I've gone pretty fast with all of this, but the last thing I wanted to highlight is our maps, because I'm hoping I'll get some of you to enter some projects onto our maps. And what you do to do that is you need to sign up as either a basic or individual or a facility, and then you can go in, and it's pretty easy. We've walked people through it. We've got the entire state of New Jersey, because of a grant, was able to have all of their hospitals sign up and put projects on the map. And it's pretty easy. You have a drop-down list that you would pick from, but there's also comment boxes where people can write in lessons learned and share other ideas with each other. And we've got now 31 states and territories with projects that have been entered, and 3 other countries, foreign countries, Canada, Brazil, and India. And we have someone out in Guam. So it's fun. Then you can search these maps, and as you see, if you're a subscriber, you can then actually get people's full contact information. So that way, then you could look up who else is working on a similar type of project as you and be able to connect with them. And boy, I went through that pretty quickly, Judy, but anyway, I'm now open for questions.
Great. Let me get myself back up in your picture. Does anyone have any questions? You can write them in the chat box, or you can go ahead and yourself and go from there.
Oh, I just noticed somebody asked if I could slow down. It's already done.
That's okay. I told them it was recorded.
Judy told me I only had 25 minutes, so then I just decided.
Yeah, you did fine. Yes, we'll post. It's all on the. We are recording this whole thing, so you'll be able to get all of it. Can you see that question there, Susan?
Yeah, I see Susan's question about hosting the PQI conference. So this would, it depends, that's probably best answered independently. So, but what we're looking for is, like NYU did, is they provided us a place to hold the conference, and then also had a certain number of their staff who were able to sign up. And that way, then we knew it was going to be worth our time to be able to run the conference, and then we did everything else. So, but yeah, I'd love to have different places in the country where we host this conference. And then it asks about where to access the recording. Judy, I think that's for you.
So Laura, this will be, it usually takes them a day, usually not much more than a day or two, and then it will be up, and we will post where that's going to be held, where that's going to be kept.
And then
go ahead.
Sorry, Rhonda asked about interested in global efforts. Yeah, so we're a lot of our action briefs and things are very focused on what's happening in the United States, but we have had people from other countries start to sign up. So yeah, help spread the word. That would be great. And if you if you want to, those that have entered projects, if you're a subscriber, a member of the organization, you can go in and connect with people that way.
And Lisa's asking how you're incorporating communities with higher rates of perinatal mortality in the organization.
Yes, so I definitely need to, we're always anxious to do more in that regard. And one of the things we've done is be able to, like for New Jersey, for example, which is a state that has one of the highest rates of maternal mortality and morbidity. We actively went and got a grant, and so that all the hospitals could be part of this project, which meant all of the staff, all of the perinatal staff in all of New Jersey have access. And that's just the first state we've started in, but that's a model that we're looking to emulate in other states. We're also been making connections with Department of Health in other states as well.
Go ahead. Yeah, I'm trying to catch them here. It says, let's see, the next question was Jennifer Wolf, who asked, how do you start engaging staff in quality improvement? That's a big issue that the students are struggling with, is how to engage their staff, who sometimes say yes and then are not as happy to oblige.
Yeah, so one of the things I found that has worked is I love Margaret Mead's quote about starting with a small group, and that's what really changes the world. And so I don't go with the naysayers. I go with the ones that are interested and willing to try, and then we work it out with them first, and then we move it on to others. So I think first working out the kinks with a smaller group is better than trying to put the whole thing out there in one, all at once. The other thing that I think works really well with kind of a tip is also helping. That's one reason I go through that whole exercise in the action brief, of having them be part of the identifying priorities for action. I've noticed, nurses who are strong advocates for patients, and if they feel like something really will make a difference, then that gets to that value fit that I showed you in the Klein-Sora theory. So you need to go, you can't skip over persuasion. People need to understand why the change is needed. Those are two tips.
It's so great, Deborah, to hear you echoing the things that we are teaching. So I'm very excited. Let's see where Ann Jopling said, do you mentor other quality improvement leaders through your organization? It looks like you provide great support.
Yeah, we're still pretty small. So if people need one-on-one mentoring, then we do need to charge for that at this point. We also, though, in the community, we're moving the action briefs into a community, an online community, so that people can mentor each other as well and support each other. So I think our goal is to have different ways of doing it. Right now, if somebody wanted coaching, just like you would go get a professional coach or to help you with like getting a new job. If people wanted to have some one-on-one mentoring, that is an option as well.
Okay, and Rhonda Adams-Hilliker asked, are there inner city initiatives that would encourage providers to do more work in such areas where ethnic disparities exist?
There are, but I don't think there's enough of them. And I also have to admit that I still need to do a lot more to reach out to, have more racial diversity within my advisory boards. And I'm always looking for people with different perspectives in different parts of the country. But I know that there are efforts to do that, in particular in New York City. There's been efforts around that for the safety bundles. But I think unfortunately, there's so much more work that needs to be done in that regard. And I need to do more in that as well.
Oops, just moved on me. Hold on. Amy Rohr, what is your recommendation for resistance within quality improvement projects? My clinic has done IHI in the past, and once they heard IHI, they ran away.
Oh, that's too bad. I'm really sorry to hear that. But I am not surprised. So, when I was the director of nursing for 2 hospitals in New York City, I loved QI even then. And I have to say that some of my managers would roll their eyes and some of the staff, but what I found helps is actually having it be a meaningful project to them, something they can relate to. So one of the things I did is, even if you just post, and data is a very effective way to do that. So I'll tell you a quick little story. Well, I really wanted to help the Neonatal Intensive Care Unit to start to be more attentive and give pain medications to the neonates, but these little babies. And I would talk to the doctors, I talked to the nurses, and everybody, wasn't that they were against it, it's just that it was new to them and they didn't really know where to begin. And so we started out by just doing pain scores and teaching people how to do pain scores. And then I started posting the pain, just the results of this, doing chart audits and posting it. And I didn't have a lot of time to put a lot of effort into that. There were other priorities that I had set. But every few months I would post a new chart up on their wall and put it on their bulletin board, and it showed that they weren't making much progress, and that I hadn't forgotten about it. And lo and behold, when I moved to California, then I was invited back and I was speaking at a March of Dimes meeting. And wouldn't you know it, the nurses from that unit had a poster, and it showed how they were that they had changed and completely changed practice and had owned that whole project themselves. So it doesn't always happen that way, but I think when nurses really understand why, and they start to really think more about it, very powerful things happen. And I think we have to be very thoughtful about where we spend our energy and what we're imposing and how many projects, how many changes all at once, and really be clear with which priorities we're setting. I mean, there are just, realities of like limitations of time and energy that people have as well.
Great. We've got a bunch of questions here. Thanks to everybody. Here's another one. Stephanie Dove, you spoke of case studies. Is there a good way to integrate case studies in a quality improvement project? And would it be more part of your planning and maybe an educational aspect?
I'm using it as both, frankly. So the action briefs I'm using that as case study approach, thinking that will help with both planning as well as engagement. So I think people learn with stories a lot better than just people talking at you. I think both.
We just had that conversation today, actually. Kitty Ernst is asking you, have you had any trouble getting physicians or any group involved with implementing the projects?
Yes, everybody. And at some hospitals, it will be the doctors are the gung-ho, and and the nurses are slowing down the progress. And but I have to say, typically, more often it's the doctors than the nurses. Usually, it's the nurses who are leading the efforts in QI, and I think that that often isn't as well recognized. But yeah, it's that's why I start with a small group and find at least a few people interested, and then it's amazing what that group can make happen. I should also add to that there are also in the earlier slide when I mentioned Weiner's work on organizational readiness, and so there are theories, and within the CFER.org, there's also even some research-based guidelines to help think about how to analyze or look at context, and also the actual innovation has characteristics that make it easier or harder to implement. And I've noticed, like, for example, with the postpartum hemorrhage project, and we're going to be publishing this paper soon, we had different implementation patterns at the same hospitals. So something like risk assessment was much easier to implement than quantifying of blood loss. And so we have to just recognize it's not always the individuals that make it harder. It's also just there's as Harvey and Kitson point out, like it's the recipients, but it's also the facilitation, how we facilitate the change, also the characteristics of the context, and then also the characteristics of the innovation. So kind of teasing those pieces out will help you think through and make a better plan. I also think I like to think of 3 different tactics or strategies, tactics within 3 major strategies. The 3 strategies being education, discourse, and data. And I wrote a paper on this, actually. I could send you the link to that, Judy, if that would be helpful. Yeah, it has a table outlining examples of tactics within those 3 strategies, because too often we go to just education as our only strategy.
Again, I'm loving that you're reiterating what we are saying over and over. Kalena Lanuza says she teaches maternal child to BSN students, and she wants to know if you have anything that can be incorporated into pre-licensure curriculum.
I have not developed that yet, but I think basically I would say, yeah, I'm just trying to think what specifically, because I spend most of my time right now thinking about the doctoral of nursing practice students, but I think all of the BSN students should learn about QI process models and at least have some introduction to them, and also thinking about strategies and tactics and the tools like fishbone diagram to be able to analyze a problem, be able to put together, think through like what's not just a PICO question, but also within what they do to and I think that strategies and tactics approach would also be good for the BSNs. So, but I should think more about that and put something out there. That was a good question.
Linda Cole just got moved. Hold on. Linda Cole asks, how do we get the most bang for the buck to make QI projects a consistent cultural behavior in an organization? And can we convince organizations that QI will make a big difference in outcomes, cost, etc.?
Yeah, I think, there are leaders who really do facilitate these contexts that are much more where QI is just the way things are done, and really how to get that consistently across the country, I think is a big challenge. But I also know from the research that even without a strong leader who's interested in QI, a lot can be done from the unit level as well and from the actual staff. So I think it needs to be both bottom up and top down. So I think we need to not think of it as any one solution. And I saw Tracy put she brings food to the projects, and I agree with that. Like anything you can do to make it fun. So.
Rhonda Hilliker, following on Kitty's question would be, Do you record success of QI projects based on first getting physicians on board and then presenting to the rest of the staff?
I usually like to have these conversations of change with not just the physicians, but I think about who are all the stakeholders who I need to work with. So one reason I particularly like the map it as a process model is it reminds you to mobilize. And this mobilization is like if you put a rock throw a rock into a pond, you start with the small group and then you'll expand. But yes, you wanna get different people on board, whoever who you're going to be making affecting the change. Sometimes though we ask permission for things that aren't really others permission to give. So if it's really changing nursing practice, then there's not really a lot of permission. You don't really need to get permission, but you might want to inform or and explain why you're doing something. So like, for example, skin to skin, putting a baby skin to skin that's really a nursing practice. It doesn't really have much effect on the doctor, though you want them to be be understanding why that's needed, and it's best if everybody's on the same page. But I think you know like what I mean by that.
Rhonda asks another question. I think she was typing very fast, but does there exist any type of hospital evaluation based on quality improvement projects and their success?
I'm not like, there are a lot of projects that have been written up in the literature, but one of the reasons, and some of them have been I think what I find a little bit hard is that then only the successes get published, right? So, and I honestly have learned the most through some of my failures, right? So the QI map is a way to get that information out faster. One of the things, like, for example, the PPH project we finished in like 2015, 2014, and it won't be published till 2018. So how do we get some lessons out earlier than, not instead of, but in addition to the publications? Mm-hmm. Did that answer the question?
I'm not sure. I think, as I said, I think she was typing really fast and that came out kind of halfway. I have one more question here. And it says, Anne says, has there been a significant improvement in implementation science through QI to the action change in practice since the DNP role has grown in the past 10 years? And how big an impact are we seeing in healthcare?
Well, honestly, I think the whole science around implementation science is still very young. And some people would like to call it implementation research in healthcare rather than, just to kind of clarify. But for example, the journal Implementation Science is only 11 years old. And so there's a lot of frameworks, determinant frameworks, and other things that have people working in isolation trying to understand implementation better. But now with this consolidated implementation framework for research, the consolidated framework for implementation science research is, that's actually gone a long ways to kind of standardize the constructs for the research. But I was just at a couple of big national meetings, and there's a lot of work needed to get implementation science methods, concepts, and QI methods and tools taught. And if we think of the history of the DNP students, and the degree that was originally started and taught by PhDs who didn't really have the foundation in that particular science. I think the theory courses haven't all caught up across the country. I don't think there's just a lot of work that we need to do to kind of strengthen the foundation, the scientific foundation for the DNPs. And when I went to the Doctor of Nursing Practice conference, almost all of the abstracts seemed to be written such that they didn't understand QI or implementation science, or at least it wasn't presented as part of their thinking and how they organize their projects. So that was across the country. Almost all of those presentations didn't have a theoretical framework guiding their work, or clearly outlining their process models and protocols and the tools and kind of thinking about it. So that's a lot of the work I'm doing at the University of Maryland, is to try to help increase that infuse those methods and tools and theories within their work.
Great. Well, there's been a lot of discussion here on the chat board, but I don't think there are any more questions. Does anyone have any more questions for Debra? This has been a great discussion.
I love Joan's comment, or let's see, like,
yes.
Oh no, Amy's comment was like, is a QI project on QI project development. Well, actually, I actually have developed a logic model for the work I'm doing to make. So I have thought of my work as a QI project. That's how I approach all my work. So I actually am doing that right now. So that was funny, Amy, that you said it that way.
And there is a question here by Emily. Thinking about the graph you showed on California and the U.S. mortality rates, what are the big steps projects California is doing to decrease maternal mortality rates?
What we did is, well, the first thing we did was went around and just told everybody there was a problem, and so helped mobilize the entire state. I went anywhere anyone would invite me and spoke to very small groups. We also then identified and pulled together some committees, and we launched two big toolkits when I was the executive director. One was the obstetric hemorrhage toolkit, and the other one was the elimination of elective deliveries prior to 39 weeks. And we also then started collaboratives, smaller hospital collaboratives, where people could learn from each other, kind of like little learning labs. And those toolkits were the first time that I think people had seen where it had all of these tools laid out so clearly. We built those based on the mortality data. So I actually wrote a paper describing that whole process, if you're interested. And then subsequently, after I left, then the second leading cause of maternal deaths in the state of California was preventable deaths was hypertension. So that was the second toolkit that they rolled out. I mean, the third toolkit that they rolled out.
Lots of wonderful comments and thanks for you here.
Oh, that's very sweet.
Well, like I said, it's so lovely to hear you, hear us and you, both of us, echoing the same kind of information that we're giving to the students and to anyone doing QI. So it's, you know, we're getting there little by little, you on your end, us on our end.
Yeah, yeah, Judy, it's so nice. I found like, you know, a simpatico, somebody, you know, think alike. It's great.
Yes. Well, I think that looks like we're ending it up. Does anyone have any more questions? I think it looks like we're good.
Great. Hopefully I see some of you at PQI at perinatalqi.org and see some of your projects on our maps to help get the word out. So thank you.
That would be great. Thank you so much, Dr. Bingham. We really appreciate it. And we will have this this whole conference recorded and will be available to everyone, so you can see all of this information. And you can go on the website, as she has right there, that you can go and get a lot of this information as well. And Debra, if you wanted to send me those that paper that you were talking about that you wrote, that would be lovely. Then I can share that with the students.
Okay, I'll send you, do you want both of them, Judy? The one about California, and then, okay, I'll send you both.
Yeah, that would be great.
Okay, great. Thanks, everybody.
Great. Thanks, everybody, for coming. Thank you, Debra. Yeah. We'll talk to you soon.
Yeah, see you in the QI world. So, bye.
Good night, everybody.